Good afternoon, and welcome to this poster session on antivirals and pregnancy. My name is Laura Gay. I'm the research professor at George Washington University and the vice president for research at the Elizabeth Glaser Pediatric AIDS Foundation, and I'm going to co-chair with Dr. Laurent Mandelbrot.
Yeah. Hello, everybody. I'm Laurent Mandelbrot.
Sounds better when he says it.
Really? Okay. Professor OBGYN in Paris. And so we're having a session, an oral poster session, which is kind of a mix of various different aspects, and I think it'll be interesting to have a group discussion at the end. And it's my pleasure to call the first speaker, who's Dr. Malaba. Dr. Malaba is a postgraduate student from the University of Cape Town in the Division of Epidemiology and Biostatistics, and her work focuses on elucidating the effects of maternal HIV exposure and treatment on maternal and child health. Dr. Malaba.
Okay, thank you. Okay. I'd like to thank the conference organizers for giving us an opportunity to present our findings. I'll be presenting on the methods of gestational age assessment influence the observed association between ART and preterm delivery. So the findings for ART use in pregnancy and preterm delivery are conflicting, with inconsistent results across different settings. Accurate gestational age assessment is critical for preterm delivery diagnosis. Assessment methods used include last menstrual period, LMP, measurement of the symphysis fundal height, SFH, and ultrasound. Each of these methods has their own limitations. So ultrasound is most accurate before 24 weeks gestation. LMP is unreliable due to recall issues, and SFH measurement is difficult early in pregnancy and in women with high BMI. So in resource-limited settings where ultrasound facilities are unavailable, LMP and SFH are often used, and this could provide one possible explanation for the heterogeneity in findings. So we examined the impact of gestational age assessment methods on the observed association between HIV, ART status, and preterm delivery. Okay. So between April 2015 and October 2016, we enrolled women, regardless of their HIV status, who were seeking antenatal care at a large primary care facility in Cape Town, South Africa. As part of routine antenatal care services, public sector midwives estimate gestation by LMP and/or SFH. So if these women had a clinical gestation less than 24 weeks, we referred them to our research sonographer, who performed an ultrasound, and she was blinded to the midwife's gestational age estimate. So analyses examined preterm delivery according to assessment methods, and we had two comparison groups. So we had HIV-infected versus HIV-uninfected, which was comparison A, and the HIV-infected women were all on ART. And among the HIV-infected women, we compared those who initiated before pregnancy and those who initiated during pregnancy. This was comparison B. So we had 1,468 women included in this analysis. Of these, 89% had an LMP based on, had a gestation based on LMP, 67% based on SFH, 66% based on ultrasound, and 34% had based on all three methods. So among the live singleton births, overall, with LMP, the preterm delivery incidence was 36%, 23% by SFH, and 12% by ultrasound. And for comparison A, which was HIV-infected versus HIV-uninfected, when we used SFH and LMP-based gestation, the incidence was similar across the comparison group. Whereas when we used ultrasound-based gestation, the incidence was higher in HIV-infected women compared to HIV-uninfected women. For comparison B, across all three assessment methods, the incidence was similar across the comparison groups. For our logistic regression, we found that using the ultrasound-based gestation, HIV-infected women were more likely to deliver preterm than HIV-uninfected women. And this persisted when we adjusted for age, parity, BMI, and previous preterm. For comparison B, across the 3 assessment groups, assessment methods, there was no differences according to timing of initiation. And this was in the adjusted and unadjusted models. So in conclusion, we found that using the ultrasound-based gestation, HIV infection was associated with preterm delivery. However, we did not observe any differences according to timing of initiation. So our results suggest that findings for HIV, ART, and preterm delivery association are substantially influenced by the gestational age assessment methods used. So this highlights the need to standardize optimal measures of gestational age. Thank you.
Thank you very much. Our next presentation will be by Dr. Dadabai, who's going to talk about, who is an epidemiologist from Johns Hopkins. She's currently the HIV clinical research site leader and field director of the NIH-funded Blantyre, Malawi site and associate director of the Hopkins Malawi Fogarty HIV Research Training Program. Dr. Dadabai.
Thank you. Good afternoon, everyone. Let me make sure I know how to pull up these slides. Do I just click? Okay, there we go. And I think it's down, yes, perfect, great. Good afternoon. Thank you for this opportunity. Thank you to the chairs, and thank you for the introduction. I have no conflicts of interest to declare, and my email address is on the screen for any follow-up questions you may have. And today I'll be presenting on our research in Blantyre, Malawi. Over the years, we've seen multiple examples of public health interventions closing the door on one problem only to crack open a window on another health challenge. The POISE study was designed with that cautionary tale in mind. POISE stands for Pregnancy Outcomes and Infant Survival in the Era of Universal Heart in Africa. What we all know well, is that access to and adherence to HEART nearly eliminate MTCT of HIV. What we do not know is whether HEART also eliminates disparities in adverse pregnancy outcomes, or does HEART exposure actually increase the risk? To answer this question, we designed a prospective study to compare preterm birth, low birth weight, and survival among infants born to ART-experienced women versus HIV-uninfected women in Blantyre, Malawi, where the first-line regimen is tenofovir, 3-TC, and efavirenz. The issue of comparing HIV-infected women on treatment versus not on treatment has already been asked and answered. We are now asking ourselves how relatively healthy women on HEART compare to their HIV-uninfected peers. The study was funded by NIH, and between January 2016 and June 2017, we enrolled 677 HIV-positive mother-infant pairs and 469 HIV-negative mother-infant pairs. They were enrolled at delivery, and of the HIV-positive mother-infant mothers, 75% were virally suppressed. Today I'll be presenting just 2 key findings. One is that we observe no significant differences between preterm birth and low birth weight between ART-exposed and unexposed infants. You can see the figures on the slide. Low birth weight was measured as defined as less than 2,500 grams, and among those ART-exposed infants, 6.8% of infants were low birth weight, and 5% of unexposed infants were low birth weight. Preterm birth exposed was about 11.3%, and unexposed, ART-unexposed, 9.6%. And just to say that we measured to tack on to Dr. Malaba's talk, we measured gestational age by Ballard score. Ultrasound is not routinely available in Malawi, and our data also confirm what she mentioned, that LMP tended to overestimate the gestational age. One observation we did make about preterm birth was that if you look at the far left column, that's ART initiation, the trimester when ART was initiated. You can see that in the third column with the percentages, we saw some trend in increase of preterm birth based on the trimester that when ART was initiated. The P4 trend was not significant. Looking at those who initiated ART before conception, we saw a preterm birth rate of 13.7%. That may suggest that maybe there's a different mechanism going on, the way that ART maybe impacts preterm birth, the risk of preterm birth before conception is somehow different than the way it impacts the risk when you've initiated once already pregnant. Our second key finding in my final slide is to highlight that mortality and MTCT of HIV are still significant public health concerns. While all women in the study with HIV were on ART for at least 1 month, most far longer than that, at least 5 infants were known to be still known to be HIV infected, so there was still maternal child transmission of HIV. To date, 7 infants have died, unfortunately, 4 in the HIV exposed group, 3 in the HIV unexposed group, and the poster outside actually details suspected causes of death. We've had only 1 woman pass away in the cohort. So in conclusion, the data are reassuring that HART can reduce MTCT of HIV without negative impact on other pregnancy outcomes. And if you have further questions, I'd be happy to answer them during the discussion or during the poster session afterwards. Thank you.
Thank you, Dr. Donovan. The next presentation is by Dr. Davis, who's an epidemiologist in the Division of Reproductive Health at the Centers for Disease Control and Prevention in the U.S., presenting on ARV concentrations in breast milk, viral load, and transmission. Dr. Davis.
Thank you very much. So on behalf of my co-authors and the BAN study team, I will be presenting our findings on whether the concentration of antiretroviral drugs found in plasma, as well as the amount of drug excreted into breast milk, was associated with HIV viral load and HIV transmission from mother to infant. We conducted a cohort study with 2-phase sampling using data from the Breastfeeding Antiretrovirals in Nutrition, or BAN study. BAN was a randomized clinical trial conducted in Lilongwe, Malawi between 2004 and 2010 to assess the benefit and safety of maternal or infant antiretrovirals to prevent HIV transmission during breastfeeding. For this analysis, we included mothers who were randomized to either 28 weeks of postpartum maternal ARVs or daily infant nevirapine, and who had at least 1 plasma or breast milk specimen available between 2 and 24 weeks postpartum. Among those, we included all 27 mothers who transmitted HIV to their infants between 2 and 28 weeks, and 15%, or 227, mothers who did not transmit, which gave us a total sample size of 254 mother-infant pairs. The reciprocal of the study inclusion probability was used as a sampling weight in all regression analyses to account for the 2-phase sampling. Plasma and breast milk drug concentrations for nevirapine, nilfinavir, and lopinavir were treated as dichotomous variables in all regression models using the median effective concentration, or EC50, as a cutoff. Maternal plasma drug concentrations were used for mother-infant pairs randomized to maternal ARVs, and infant nevirapine plasma concentrations were used for mother-infant pairs randomized to infant nevirapine. Plasma and breast milk viral load were dichotomized as detectable or undetectable. Detectable was defined as having a plasma viral load greater than 40 copies per mil, or a breast milk viral load greater than 56 copies per mil. Our first aim was to examine the correlation between plasma and breast milk ARV drug concentrations in the women randomized to maternal ARVs using Spearman correlation coefficients. The figure presented here plots plasma concentrations on the x-axis by breast milk concentrations on the y-axis. The different symbols represent the different antiretrovirals, which included lamivudine, zidovudine, nilfinavir, lopinavir, and nevirapine. All ARV compounds exhibited substantial correlations between maternal plasma and breast milk concentrations, with correlation coefficients ranging between 0.85 and 0.98. Our second aim was to estimate associations between maternal ARV drug concentrations by compartment and detectable maternal plasma and breast milk viral load using mixed effects models, and including only mothers randomized to maternal ARVs. Nearly 70% of mothers randomized to maternal ARVs received a boosted protease inhibitor regimen of zidovudine, lamivudine, and lopinavir ritonavir. The results for our second aim are presented in the first table, which I will go over momentarily. Our third aim was to compare time to breast milk HIV transmission by plasma and breast milk drug concentration status using Cox models. The results of the third aim are presented in the second table and include data from mothers randomized to maternal ARVs and infants randomized to daily infant nevirapine, when plasma drug concentration was the exposure. Only the maternal ARV arm was included when breast milk drug concentration was the exposure, limiting the number of transmissions to 13 instead of 27. Having plasma drug concentrations above the EC50 was associated with a lower odds of having detectable HIV RNA in both plasma and breast milk. And it was associated with a reduced rate of breast milk HIV transmission between 2 and 28 weeks postpartum. Having breast milk drug concentration above the EC50 was also associated with a lower odds of having detectable HIV RNA in both plasma and breast milk. The lack of a statistically significant association between breast milk drug concentration and HIV transmission may have been due to the small number of transmission events in that model. Based on these findings, we conclude that ensuring adequate drug concentration in both plasma and breast milk is important for reaching and maintaining viral suppression and preventing breast milk HIV transmission. We would like to thank the conference organizers for allowing us to present this work, and we'd like to express our gratitude to the entire band study team, and most importantly, to the women and infants that agreed to participate in the band study.
Thank you. We'll now move on to the next talk by Graziella Favaro, who works in, she's an epidemiologist and has been working for several years on HIV and pregnancy at the Institute of Child Health in college in London, and previously worked on respiratory diseases and air pollution. So we'll be talking about this stillbirths in HIV-infected women.
In UK and Ireland. Thank you. So the background of this work is stillbirth. Causes of stillbirth are multifactorial and incompletely understood. It has been previously reported higher stillbirth rate in HIV-infected women in UK and Ireland. The aim of this study was to explore the current rate of stillbirth and explore also the associated risk factors in HIV-infected women delivering UK, Ireland. To do this, we use data from a national surveillance study that routinely collects data in pregnant women delivering in HIV-infected pregnant women delivering UK and Ireland, called the NSHPC. So the study period was from 2007 to 2015. The inclusion criteria, we included only singleton birth and deliver at least at 24 gestational weeks. The definition of stillbirth was an infant delivered at least at 24 gestational weeks, showing no signs of life. To explore the risk factors associated with stillbirth, we use multivariable Poisson regression. Between 2007 and 2015, over 10,400 singleton pregnancies were reported to the NSHPC. Among these pregnancies, there were 89 stillbirths, the equivalent of approximately 0.9%. This percentage varied a little bit. It was lower in the last few years of our study period. From 2013 to 2015, it was only 0.6% of stillbirth. It was lower among women who were born in Europe or other westernized countries, 0.4%, while it was considerably higher in women who were born in sub-Saharan Africa on other parts of the world. Of note, women from sub-Saharan Africa are the largest group in our cohort study. In fact, out of 10,400 pregnancies, 7,752 were women who were born from sub-Saharan Africa. Stillbirth rate was also lower in younger women. It was lower in multiparous women, and as expected, also it was lower in women with a higher CD4 count, above 350. We also looked at the antenatal ART regimens women were in pregnancy. There was not much difference in stillbirth rate, whether the woman was on a PI-based regimen or on an RTI-based regimens, which are the most popular regimens women are at the moment. Stillbirth rate was higher in women on integrase inhibitors, 1.7%, but we must say that the group was very small because it just started to be prescribed to women. So we had only 120 women on integrase inhibitors. And other regimens, which include women on mono or dual regimens, there were no stillbirths. This is very characteristic of the early study period. The infants, compared to live-born infants, they were more likely to born preterm, even very preterm. Nearly over 50% of stillbirths were born before 34 gestational weeks, compared to only 4% of live births. They were also smaller for gestational age, and they tended to be of male gender, and also congenital abnormalities were more frequent, around 50% compared to only 3% in the live birth singleton. Results from our multivariable analysis identified as significant risk factors, having a low antenatal CD4 count, being premiparous, being of older age, and being born from sub-Saharan Africa or other part of the world, compared to being born in Europe or other westernized countries. The study had some limitations. We could not adjust for other non-risk factors for stillbirths, mainly socioeconomic status, smoking, and the BMI, because the NSHPC doesn't collect routinely this data. And also we were unable to classify whether the stillbirth was antepartum or intrapartum. And in conclusion, so we found that the stillbirth rate is 0.9%, which is higher than the UK the stillbirth in the UK general population, which is approximately 0.5%. But I must say that when we look into the stillbirth rate in the general populations, it varies, and it is much higher in migrant women, especially from sub-Saharan Africa or Asia. And the rate reaches quite similar to the stillbirth rate that we come across in our cohort study. And that's what is something, future work that we wanted to conduct further analysis by standardizing stillbirth by maternal origin. And also we wanted to conduct an embedded audit to enhance the data collections, particularly to find out the rate of preeclampsia and other comorbidities. That's it. Thank you.
Thank you very much, Gracia. We're right on time. So the next speaker is Dr. Angelina Anameba, who's going to talk about a study from Cambodia. She's a PhD in epidemiology and cost effectiveness. And since this year, she's a research project leader at Action Against Hunger. Dr. Angelou.
Hello. Thank you to the organizer for giving me the opportunity to present this result today. I'm presenting the INRS study called the Performance on 2 HBV Rapid Diagnostic Tests to Identify Pregnant Women at Risk of HBV Mother-to-Child Transmission in Cambodia. International guidelines suggest or recommend the administration of anti-HBV drugs like tenofovir during the 3rd trimester of pregnancy if the viral levels are high to reduce HBV mother-to-child transmission. But the question is how to apply those guidelines in Cambodia, where the prevalence is 5 to 10% in the general population and where the screening rate during pregnancy is really low. There is poor laboratory facilities in healthcare center where antenatal care takes place, and there is also very poor access to viral load quantification, notably in a decentralized area. So the objective of this study is to evaluate the performance of a new diagnosis algorithm using both HBs antigen and HBe antigen rapid diagnostic test to identify pregnant women at risk of HBV mother-to-child transmission. So we selected 250 pregnant women during their antenatal care at the Calmette Hospital in Phnom Penh, with at least 125 known HBs positive, and they were tested with this rapid diagnostic test-based algorithm and compared to gold standard. So first, the performance of HBs rapid diagnostic test to detect HBV infection was done and compared to ELISA among all the pregnant women. And secondly, HBe rapid diagnostics test was tested as a surrogate marker for viral load and was compared to normal quantification among women found positive for HBs. So the median age of our population was 29 years, and among the 128 women with HBs positivity, 26% were found to have a viral load above 5.3 and 21% above 7.3. 23% were tested positive with the HBe rapid diagnostic test. Sensitivity of HBs rapid diagnostic test was 99% compared to ELISA, and the specificity was 100. HBe rapid test was found to have a sensitivity of 76 for the 5.3 threshold, 79 for the 6.3 threshold, and 89 for the 7.3 threshold. Specificity rate ranged from 96 to 97. Among the HBV-infected women, the distribution of viral load showed that 63% of them had a very low viral load and that 26% of them had a viral load above 3.3. And the median value of viral quantification was 8.4 in the positive HBe rapid diagnostic test and 2.2 in the negative HBe rapid diagnostic test, and showed significant difference. Genetic analysis on the discordant cases, meaning the cases with a negative HBe rapid diagnostic test but a high viral load, show that 7 of the 8 women carried the precore mutation. So our findings are that HBs rapid diagnostic test to detect HBV infection during antenatal care shows excellent sensitivity and specificity. This is a point-of-care testing with a low cost that might be adapted to routine screening during antenatal care in decentralized area. HBe rapid diagnostic test to predict viral load among HBs positive women shows excellent specificity. However, the sensitivity is low, which might be related to the precore mutation. However, the sensitivity increased for higher viral load rates, notably for rates above 7.3, where the main transmission has been shown to occur. Those results come from a small sample made on older women in the Phnom Penh area only, so they need to be confirmed with a larger and more representative sampling, which is going to be the case for the ANRS study. called TAPROM, currently implemented in Phnom Penh. Viral load showed that 63% of the women were at low risk and that 26% were at very high risk. Tenofovir has shown effectiveness and safety to reduce mother-to-child transmission for high women in China, in a RCT, and this drug is largely available in Cambodia. So our findings are that this algorithm could be useful and cost-effective to detect pregnant women at risk of HBV mother-to-child transmission and could predict the eligibility for TDF indication in a country where viral load is not readily available. But the impact of those mutants needs to be confirmed in a larger sample size. Thank you for attention.
Thank you very much.
We'll call all the great talks. Thanks everybody for staying on time, and we'll be able to start a discussion if everybody can. You have your names up here. Okay.
Do 3 questions at once, or one by one? One by one. There's a microphone, one on each side toward the front. If you have any questions, please come to the microphone and introduce yourself, and then let us know who you're asking your question of. On the left.
Thank you very much. I just want to say thank you very much to all the speakers. That was really informative. My name is Angelina Anameba, and I work for the Salamander Trust, which is a small charity based in the UK, but we work with women living with HIV globally as well. My question is to the last speaker, Lisa. I really enjoyed your presentation, but I wanted to find out, because you said you had 100% retention and I think 97% adherence. I just want to find out what it was that you put into place to enable these women to actually adhere so well, because I mean, I'm sure a lot of other people can learn from what you did probably in terms of keeping women engaged in clinical trials, for example. Just wanted to know what you put into place.
Thanks. I think this is a very different kind of study, this phase 1 PK, or you could say a phase 3B or beyond. This kind of study was really about asking, does the dipivirine go from the ring to the milk? And it answered we did. But this isn't a phase 3 or phase 4 kind of study where we're drawing from the average population or typical population at risk. So women were selected from these US-based sites with the idea in mind that probably they would be able to adhere. So I think this is a very select population. It wasn't sort of a mainstream population of women at risk for HIV infection. That being said, I think the study team did a great job of continuing to follow up with women by phone during the short study. It was only 16 days, so thank you, though.
Hi. I think this is a question for the second speaker. That was great. I'm glad this work is going on in other countries. We do this a lot in Botswana. And I was wondering which ART regimen you were using, and I'm asking because I think, at least from our large studies in Botswana, there seems to be major differences in birth outcomes by ART regimen. So I wonder if the differences, the lack of differences you're seeing were related to ART.
Are they on? Hello. Hi, thank you. Thank you for the great question. Yes, so the first-line regimen in Malawi is tenofovir, efavirenz, and lamivudine. And you're absolutely right. I think most of the adverse birth outcomes, adverse pregnancy outcomes we see are PI-based regimens, are related to PI-based regimens. We had very, very, very few women on those regimens. They're switching to second line or third line in Malawi is very rare. It's difficult to prove virologic failure. It's difficult to prove resistance issues given the lack of availability of testing. So most women are on that first line, which is doesn't have any PI-based regimens. So I think to your point, yes, that was definitely part of the reason probably we didn't observe the difference. Mm-hmm.
And if I can ask the first speaker a question as well. I was really surprised by the magnitude of difference between the ultrasound and the LMP. I mean, it was like 3 times as high for preterm. And I was wondering if you had some ideas why that was, and also if you found the same thing with birth weight. Did you look at birth weight as an outcome?
No, we didn't look at birth weight. We just looked at preterm delivery. Yeah, it was quite surprising, the difference. I think just in this setting, the setting that... Okay. Hello? Okay, there we go. In our setting, LMP, women don't tend to remember when their last LMP, last menstrual period was. So I guess that's why.
Next question.
Thank you very much, everyone, for the great presentation. My question also goes to the first speaker. Just given that in sub-Saharan Africa, we do have option P plus being implemented and the different associations you've seen given the different measurements for gestational age, I just wondered what your recommendation would be, given that we know we won't have ultrasound in many of these settings. And then my question goes to speaker number 2 as well, just in terms of what methods you used for gestational age in your study.
Thank you. It's a great question. I think in our setting, well, in these settings where we don't have ultrasounds, we now have to start looking at validating. So maybe now doing some postnatal validation of gestation, not just antenatal.
Sure, absolutely. Thank you for the question. So in our setting, again, ultrasound is not routinely available. It's rare to be able to access the ultrasound. It's not that the machine's not there. The demand for it is high. The calibration, the accuracy of the machine is questionable. So we use the Ballard scoring method. And interestingly, as I mentioned in the presentation, when we also captured last menstrual period as an alternative. And when we did the math, it was 2 to 3 times higher. The gestational age was inaccurate based on the LMP for probably similar reasons. The recall is very poor. And I don't think that's unique to sub-Saharan African women. I think probably LMP is difficult to remember for women all around the world. So I don't think that's unique to our setting in Malawi. So Ballard scoring is the one that we use the most in research settings. And that's even in NIH-funded trials as well as in probably standard of care, less so, but in all of our research trials, Ballard score is what we've used.
Question from
I have two questions, one for Nicole Davis. Do you feel that your data are strong enough to conclude that monitoring the plasma would be enough in terms of safety of breastfeeding? I mean, you do the plasma and then you may not do anything in the breast milk.
Very strong statement. So I think I would hold off on saying that right now, but it's a good point.
We have to monitor this woman anyway. And one question for Graziella Favarato. You showed that you evaluate the stillbirth rate according to PI and NRTI and integrase inhibitor. Did you check the nucleosides? Are there differences among nucleoside analogs?
No. The definition was what we look at, what PI-based regimen, which means PI plus 2 nucleosides. But
Yes,
we didn't look at the difference. No, I didn't.
You had different nucleosides like tenofovir.
No, I didn't check that. We didn't.
Okay,
No.
thank you.
Any more questions? While somebody's getting up to ask another question, maybe go back to the POISE study, because there was a question a few minutes ago saying, what's the difference finally between the POISE study and the PROMISE? And maybe if you wanted to maybe go into a little more detail, it seems to me there's totally different approaches. In the POISE study, the controls were women with HIV negative controls without any antiretrovirals, whereas in PROMISE it was a different type of antiretroviral approach. But
Correct.
Yeah, is that the case?
Sure, absolutely. Yes, I echo exactly what you said. The study objectives were quite different in PROMISE. We were comparing all the women and all the mother-infant pairs enrolled were HIV-infected, ART exposed, as opposed to POISE, where we're comparing HIV uninfected women and HIV infected on ART, you had to have the eligibility criteria included CD4 over 350 and no stage 3 or 4 disease. So we were actually trying to look at suppressed, healthy, relatively healthy HIV-infected women and comparing them to their uninfected peers. And the objective, of course, for PROMISE was mainly looking at how to optimize the maternal and infant ART regimens to reduce PMTCT. So it was a slightly different objective and different population. That's right. Thank you.
So in follow-up to that, then, would you hypothesize then that some of the differences in other literature that we see may be related to the fact that these are high CD4 count women, healthy women, when looking at overall outcomes, because we're seeing different results, that it may be due to actually looking at those women who are healthy compared to those HIV-infected women with low CD4 count who are exposed to antiretrovirals, which might have different results?
Exactly. I think that's exactly correct. Thank you.
Must be a bunch of other questions.
Other questions?
Questions about breastfeeding? Can you get up to the microphone? There are 2 microphones, one on the right, one on the left. And it would be really nice if you could introduce yourselves when you... Yeah, okay, you've just...
What do you do when you have bleeding nipples?
Oh.
You know, cracked nipples?
You're asking to who?
That's for Dr. Davis.
So actually, Sabrina Zadrozny just published a paper on mastitis in the BAN study. So I think that would be a good resource to look at how they looked at mastitis in BAN and what associations she found. I can, if you come to see me afterwards, I'll give you the exact citation of that. I was not involved in that part of the study, so I can't say for sure. In terms of collection of breast milk for this study, the breast milk was collected from the right breast unless there were sort of advanced mastitis, and then it was collected from the left breast.
Maybe another question on this issue. Basically, if you're talking about preventing transmission with maternal antiretroviral therapy, is it TASP or is it PrEP that you're talking about? And in your conclusion, you would seem to say that it was important to have the antiretroviral get into the breast milk to protect the baby to some extent. Do you have any hypotheses about that? I was also interested to see that there wasn't really such a correlation between the efficacy, or say the transmission, and the amount of drug that was in the breast milk. Is your feeling just that getting the maternal viral load down is the key factor to preventing breast milk transmission, or do you feel that getting the drug across into the baby by breastfeeding is important too? Or do you have any hypotheses? Is that something you're looking into or modeling?
So in previous work, we've looked at adherence by pill count and self-report and how that associates with viral load and HIV transmission. So I published that work in AIDS in 2014 and in JADES last year. And we do see a strong association between adherence by self-report or by pill count and viral load, and also by viral load measured in plasma and breast milk and HIV transmission. Here we further that work to look at drug concentration, how that associates with viral load and transmission, which also are strong associations. So I think it is a causal pathway to say, clearly taking the drug affects the viral load and affects transmission. Is one enough over the other? I can't say for sure right now. In terms of the breast milk concentration not being statistically associated with transmission, I really think that was probably due to the limited number of transmissions. So the point estimate was similar to that of plasma. In fact, it was a little bit stronger, but we just had no precision around that estimate. There was only 13 transmissions in that model as opposed to 27 in the plasma model. And I really think that was probably the reason that was not statistically associated. I don't think it's because breast milk concentration is not important.
Thank you. Amy Sloger from South Africa. The question is again about the POISE study to Sophia. So can you reassure us perhaps that there wasn't selection bias in this population of women that were included, because enrollment, as I understand, was at birth? And is there the possibility in Malawi that preterm births might potentially occur more often out of hospital and may not actually be, a significant proportion of them might not actually be delivering in facilities if mom's going to preterm labor at home. As well as I missed what the level of the 4 healthcare facilities was. Are they district hospitals? Are these tertiary hospitals? And that may also bias, the population that's enrolled in this study.
Sure, absolutely. Thank you for the great question. So I can speak to both. I think the first one is about one was about the type of facilities, and the other was the first
More
one.
preterm deliveries occurring at home. And
That's
not
right. That's
getting
right.
to facilities.
So in our context, the 5 health facilities we sampled from, the one was Queen Elizabeth Central Hospital, which is a tertiary referral hospital, and the other 4 facilities were health centers, large, high-volume health centers, all in Blantyre District. And it's true that if any case with complications tends to get referred to the referral hospital, to Queen Elizabeth Central Hospital. I think those were the levels. So there were large health centers with high volume, and this large hospital setting, which serves the entire district, the southern region. I think the other point to keep in mind is that the sampling was within Blantyre District. This was not in a rural setting. This was mainly urban setting, mainly some peri-urban, but largely urban setting. So if you look at the DHS results, the Demographic and Health Survey results for Malawi, comparing 2010 to 2015, the rate of antenatal care and the rate of delivery in hospitals has gone up drastically. So I wouldn't say that that's a huge driver of the results that we saw. I wouldn't say that that was a source of selection bias. I think that could be the case in more rural areas, more remote areas, where access to hospital-based or healthcare facility-based labor and delivery services would be an issue. But in Blantyre District, I wouldn't say that that's a big driver. But I think that's an excellent point. If we were to do the study in a different setting in the same country, that could be...
Antenatal enrollments, perhaps, to determine then outcomes at both.
Mm-hmm, that's right. There's been a huge push. It's been one of the Ministry of Health, the government's major pushes is to really discourage at-home births and to encourage, antenatal care as soon as possible. We're still not getting most women in the first trimester, but we're mainly seeing them in the second trimester. And there's been quite a substantial increase since 2010 to 2015 in those national numbers, and also a push for facility-based deliveries. So I think that's a great point. I think we did consider that, but in our population, our setting, probably not the biggest issue. Thank you.
Thanks a lot. I get a feeling it's wonderful to see how the integration of prenatal care, good prenatal care, we're talking about ultrasound, first trimester follow-up, prenatal assistance and so forth, is so important to all of us, and it's really nice to hear that. I think we have time for 1 or 2 last questions, yeah?
Hello, I'm a neonatologist. I work in Eastern Europe and Republic of Moldova. So we as neonatologists are very linked to the breastfeeding and to the mother milk, etc. So our country chose to formula feed all children, all newborns who are born from HIV positive mother. But I have, during the last years, I have such situation. So we have a mother with a 0 viral load, with 100% adherence to treatment during pregnancy. We treat anyway the newborn, so why we cannot breastfeed him? Or at least to propose to the mother the choice, because they don't have a choice. They are said you'll formula feed and it's all.
If that's really for the whole panel, they should have had a whole session on that issue. I don't know why.
The question is about the guidelines for requiring formula feeding for all HIV-infected women, even if they're suppressed?
Well, that's
that's
European or North American guidelines, which are, of course, not the case, which is not the case in sub-Saharan Africa, of course. I don't know if we can. We can always open. I think it's a very, very important point, but it's beyond the scope of the posters which was presented this morning.
Okay, so I forgot to mention that I also sit on the steering group for the National Study of HIV in Pregnancy and Childhood that Graziella mentioned earlier, alluded to earlier. But we have the same situation in the UK. However, because they still recommend formula feeding. However, in 2012, what they clinicians did in the UK was they introduced a statement whereby they say that if women wanted to strongly breastfeed, because you have to give them the choice. They said if women strongly want to breastfeed, that they should be supported to do it safely. they'll be given the information, they'll be told this is still the guidelines. However, now we've got women who are starting to breastfeed, but they're monitored really rigorously. But it's down to choice and the information that you give to the women. But also what was key was one of the reasons some women wanted to breastfeed was because they hadn't told their significant others, or they were living in situations where people didn't know their status. And so what was made clear within the guidelines or the statement was that the women who can breastfeed should know it's not just about, I want to breastfeed. It's about, am I going to keep engaged in healthcare? Am I going to go for monitoring, etc.? So there is that choice, although it's not being offered everywhere, but we've kind of changed the guidelines slightly. We've included that statement in there.
Thank you.
Thank you. I think we'll probably have to, the same discussion is going on in all the, say, guideline groups with the same, in France. Philippe Van der Per, who's sitting right over here, was proposing the BMG, using PrEP for all exposed babies, but that's something a lot of pediatricians and perinatologists are afraid of in Europe, which is exposing the baby to several drugs, all the ones that the mother's taking, plus the ones that the baby will be taking. That could be a cocktail of 4 or 5 drugs for several weeks or months. So that was one of the main concerns also that we put in the guidelines. I don't know how you feel about that. There's another question over there.
Taha from Johns Hopkins University. Just to give you an idea about the amount of transmission postpartum, and this is from the PROMISE study, hopefully this data will be available very soon. Very little, I mean, of this large cohort that has been done in several sub-Saharan African countries, just to give you an absolute number, there were only about 12 babies that have been infected from a cohort of more than 2,000. So some of our colleagues from UK did contact us, and we provided the data. So we understand that possibly this will change the guidelines so that women can breastfeed, if they are obviously on treatment.
We're under 3 per 1,000 transmissions in Western Europe, so that sounds a lot. That sounds like the figures are very high if you say 12 per 1,000.
No, they were only
12 per 2,000, that's a lot of transmission.
12 children who have been infected postpartum during the breastfeeding period from a cohort of more than 2,000.
Yeah. I mean, our objective when you say zero transmission would be, yeah, that's 6 out of,
not zero, but it is
that's
very
6 per 1,000, which is, yeah. And we're under 3 per 1,000 in terms of mother-to-child transmission in France.
So let me just qualify that transmission occurred very later on, after some women stopped breastfeeding, after some women stopped ART, because that was the design of the study. But during the first period, that was very low. Most of these transmissions actually occurred very late, after the women have stopped taking antiretrovirals.
So this is a good topic for the guidelines committee to look at the data across and make some new guidelines.
And that was, of course, in a clinical trial setting where there was very active follow-up and a lot of support for the mother-infant pairs. Certainly in POISE, it was an observational setting. We had several more higher transmission rate because of probably the lack of support for the mothers.
Last question. I think we have time for one last question.
So it's Justina Kowalska from Poland. Coming back to breastfeeding guidelines, I think we are at the edge of really rethinking it. And Swiss, I'm not sure if anybody from Switzerland is here, but Swiss, they have changed their guidelines, and probably they are not so aware, we are not so aware about it because they are in German. But they actually, I mean, so they should do it in English, I think, but they advise breastfeeding if there is zero viral load and a mother on a fully adherent treatment. So, and by the way, I would like to advertise a session that will be held at the European AIDS Clinical Society Conference in Milano this year about the breastfeeding. There will be a session challenging between the gynecologist, pediatrician. So a very early morning one, but take your breakfast and come. Thank you.
Okay, I think we'll wrap it up. Maybe let my co-chair wrap up the session. Thank you very much for all the presentations. It's been great.